recording. All right, then I can take your evenings and your mornings.
Good evening, is it good from Ghana?
Anyone here?
From Cape Town.
Cape Town is good evening, I'm sure.
It's, yes, good evening.
That's a
hello, good evening.
Good evening. Oh, is that Dr. Sunny?
It's Sunny, yeah.
A long time. How are you?
I'm all right. I'm in a heap of so many things, but yeah.
You juggle many balls. Very
good to see you.
Yeah, very good to see you too. Hi, Rhoda. Hello.
Hi, how are you?
I'm fine. How was your day today?
My day was good, busy but good, and excited to be here. Thank you for the invite.
Oh, good to see you. Florence, hi.
Hello, good evening.
Good evening. Agneta, hello. Ahmed, hello. Bridget, hello. As you can see, I'm just going down the alphabetical list.
Yes, hello, Ruth Pal.
Hi, how are you? Hi, Hassan.
Hi, good evening, everyone.
Good evening. Good evening. We are going to start at 5 past the hour, so this is just me saying hello to everyone so that we get to hear your voices. Hi, Susan. Yagama, hello. Habu, hello.
Hi.
Hi. So I'm still waiting. I think in Poland it was good morning, right? Is he still here? Jonaska was his name. No, I think
good afternoon in Poland, I think.
It was afternoon already, so it's on. Yeah. It's on good morning in the US, right?
Yeah, I think they're about the same time as Ghana.
Ah, okay.
Which country is that?
Poland.
Yes, Poland. That's right. Janu said it's GMT. Yeah, his time was the same.
But we've lost him.
He'll be back.
Okay, so it's about to be 5 past the hour. I want to invite you and welcome you on behalf of a group of minds that came together very many months ago, brought together by Gilbert, and are excited about ensuring that many people around Africa are working together, forming a movement and thinking about the quality and safety of patient care on the continent. Some are frontline health workers, most are frontline health workers, others are just interested in the topic, and you're all welcome. So thank you so much for investing your Tuesday evening time with us. My name is Ruth Palnganga, and I'm moderating today's session on behalf of OTCHI. OTCHI is one of the organizations that put this together. We are called the African Consortium for Frontline Healthcare in Africa. Today, we have an amazing panel and an amazing set of presentations. And we'll be talking about frontline healthcare workers and perhaps enlightening them, speaking to them about things that they can do to keep their eyes on the quality of healthcare and provide us with the best patient care we can do. But before we dive into the panel introductions, I want to take the temperature in the room. So again, I invite you to unmute and say hello. How many of us work in healthcare? So you can unmute or you can put your hand up on these reactions. How many of us are working in healthcare? If you put your hand up, I will see the reaction on the side. Aha. Okay, I see a lot of us work in healthcare. Okay. So we can put our hands down. So you go back and click again. And then the next question is, how many of us have visited a hospital because of COVID-19? So it's either that you experienced it as an illness or you got the COVID-19 vaccine. How many of us have visited a hospital for that reason in this year, over the past year? Another reason, you can put your hand up on the reactions over there. How many of us thank you for your hands. The last question. How many of us are convinced that something good can be done about the healthcare and the health services on this continent. And you want to be a part of making that happen. If you're convinced, again, you can put your hand up on the reactions. Again, a majority of you, over half. Wow, wow, well done. Good job. This makes me very, very happy. Thank you, that's awesome. You can click on it and put your hand down today. Our goal is that whatever your role is in healthcare, that you will come away with something, a new idea, a fresh perspective, a new strategy that you can apply and to engage the healthcare industry in whatever way that you're involved in it. So here's the format of what we're going to do today. This is what you can expect. We'll take a few moments for each of the organizers to briefly introduce themselves and tell us a little bit about their background in quality healthcare. Then we will go ahead and listen to presentations from Ghana and Kenya about COVID-19, and from the patient point of view, we'll hear from Elom and from Mary. Then I'll kick off our discussion with a few questions around their presentations. And then we'll come to the second half of our conversation today. We'll open the floor to a panel of African citizens that have gladly agreed to share with us from their lived patient experiences. Then we'll unmute and open up the discussions to all of us to give us an opportunity to ask specific questions that you've been thinking about to help us all navigate the opportunities and the challenges around frontline healthcare on the continent. Does this sound good to you? I'm seeing just a one nodding head, but I'm assuming that behind our screens, there's a lot of yeses. So then let's go ahead, and I'm going to invite Jackie to start us off, and then we'll go to Elom, and then Mary, Lydia, and then Dr. Soni, in that order.
Thank you so much, Ruth Pearl. It's an absolute pleasure to be here. I'm Jackie Stewart. I'm the Chief Executive of the Council for Health Service Accreditation of Southern Africa, COSASA, based in Cape Town. We do quality improvement and accreditation of healthcare facilities, and I'm absolutely delighted that we work right across the continent. We're in about 13 countries across the continent at the moment, predominantly in Anglophone Africa. But we are doing a little bit of work in one French-speaking country. And I'm passionate about quality. I believe that accreditation through COVID has actually shown that accreditation works and that it helps people keep focused. It makes sure that people have got standards to work to and they know what they're doing. And I genuinely believe it adds value. So I'm happy to promote accreditation as one particular vehicle for helping quality improvement. And my passion is that we improve the quality of services, that we ensure that all our staff and all our patients are safe. And that's what we all have to strive for. Thank you.
Thank you, COSASA and Jackie.
Let me go ahead and introduce myself. My name is Mary Adam. I'm a pediatrician who works at Kajabi Hospital, and I, along with Ruth Pearl and Lydia Okatoy, are co-founders of ACQUIRE, the Africa Consortium for Quality Improvement Research in Frontline Healthcare. Delighted to be with you all today.
Lydia?
Great. Good evening, colleagues. Let me put my camera on for a short while. Yes, my lighting is not so good. So my name is Lydia. I work at Kenyatta National Hospital.
We can see you clearly, Lydia. Go ahead.
Great. As a director at Healthcare Quality Department, that just division supporting how care is provided and supporting the front line to ensure that care is safe, effective, and that it is patient-centered. On the other front, I support, I'm the interim president, Society for Quality Healthcare, a new group of professionals that are coming together to support the narrative and the discussion around quality in a systematic manner, forming a professional society in Kenya. So it is one in the landscape of quality in Kenya. And I'm glad to also support Acquire Director. I believe that it is possible to invest in the frontline healthcare workers to enable them to acquire skills so that whatever they do is measurable and it is targeted towards improving the experience of the patient, and even just having our resources being channeled in a manner that can be traceable to what is a value add to the patient. I'm glad to be here. Thank you very much.
Thank you, Lydia. Dr. Soni? If Dr. Soni is not ready, Elom, maybe you can go ahead.
Yes, so thank you very much. So my name is Elom OTCHI, and I work with AFICSA. I'm the Technical Director for AFICSA. AFICSA is Africa Institute for Healthcare Quality, Safety and Accreditation. And we provide support in terms of training and capacity building for individuals and organizations as far as healthcare is concerned. So thank you, over.
Thank you, Elom.
There's Gilbert Ruthville.
We'll be hearing from Elom just in about 2 minutes. Let me speak about, Gilbert is coming. He's going to tell us the purpose of the program. He's going to give us an idea in 2 minutes about why he brought us all together. Gilbert, go ahead. You are muted.
Yes. You know, we're still grappling with talking to ourselves and enjoying it and thinking everybody hears us. So my name is Gilbert Buckle. I'm a public health physician. My areas of interest is health systems and quality in healthcare. I'm the executive director of AFICSA, of which Elom is the technical director. So ourselves, meaning Acquire, Ruthbel, Lydia, and Mary. We're also looking at AFICSA, which is myself and Elom. Dr. Tony Soni is online. We'll get him to speak. He's with Patient Safety Africa, based in Nigeria. And Jackie Stewart from Kosasa in South Africa. We realized we were kindred spirit and of like-minded, met ourselves in different ways, and we've stayed on this journey over the last nearly a year now, Ruthbel. I stand to be corrected, in bits and pieces. We're all passionate about the quality of care that we receive in our healthcare system in the continent. And we said, you know what? We have the same passion, we have the same agenda. We're all interested in the care that comes out of our healthcare facilities. So we decided to put our best foot forward during this Patient Safety Week. And we decided to have this session, put the invitation out around the continent, and let's see whether we can discuss, share experiences, come up with some suggestions on the situation of patient safety on the continent, on the possible solutions to improving patient safety on the continent. So we have a 2-day event. Today is looking at the patients themselves and some other information from some of the other panelists. And on Thursday, we have the second event, which is looking at the leaders and the leadership in the healthcare space, and what they are doing, what they want to do, and how they can do it better for all of us. It's totally my pleasure to be here for us, even just before we were debating, this thing, but we believe where 2 or 3 are gathered, hey, everything will happen in a marvelous way. So you're all most welcome, and thank you for the opportunity. Thank you, Ruthbel. Over.
Thank you, Gilbert. So we've spent 10 minutes doing what everyone dislikes doing, which is just talking about ourselves. I promise you for the next hour, we'll be focusing on the topic. We really want to have a discussion and just have a perspective about what does patient care need from the patient's perspective. So we're going to hear from Elom, who is going to present on adverse events in a tertiary hospital in Ghana.
Thank you very much, Ruthbel. So we go. So this is my topic as has been introduced, and we'll look at the health system's causes of adverse events among obstetric clients. So this is the outline, and I'll do this quickly. I like this statement by the Patient Safety Regional Focal Point for the WHO. He says that there is no quality without safety and no safety without quality. Safety is at a virgin state in most African countries, and I added including Ghana. And it is difficult to prioritize patient safety action unless it is explained in terms of how it contributes to systems strengthening. And this is the where I situate my presentation. So what are adverse events? I mean, they are unintended injuries and poor patient outcomes, and they happen as a result of medical management other than the patient's own underlying medical conditions. So an adverse event should lead to any one of these or all of them: temporary or permanent disability, prolonged hospitalization, life-sustaining intervention, and or death. And what is an unintended injury? That is also what any disadvantage for the patient that leads to prolonged or strengthened treatment, temporary or permanent impairment or death. So there's some brief on the burden of unsafe care. There's globally 43 million adverse events that are occurring every year, and more than 2/3 of these are occurring in our part of the world, lower middle income countries, including Ghana. If you look at obstetric adverse events, it says that it accounts for about 2.6 per 1,000 hospital discharges worldwide. This is by the Agency for Healthcare Research. And then it is also associated with an excess mortality of 15 deaths per 10,000.
Very true.
I lost out briefly.
Oh, okay, you're back.
Yes, yes, I'm back. Sorry. Okay. Yeah.
Okay, I think we lost you about 2 slides ago.
Yeah.
Wow. Okay. So is it here?
No.
Yeah, maybe you turn off your video and see if you can turn off your video and see.
Yeah, you can take it from here.
Okay, so I take it from here.
Yeah, that's right. Thank you.
Okay. Yeah, so adverse events are unintended injuries, and they are poor patient outcomes as a result of medical management other than the patient's own underlying medical conditions. And it will lead to any one of these or all of them: permanent disability or temporary, prolonged hospitalization, life-sustaining intervention, and or death. And an unintended injury is any disadvantage for the patient that leads to prolonged or strengthened treatment. So there's some statistic on the burden of unsafe care. Yeah, so there is 43 million adverse events that occur each year worldwide, and these are causing 23 million disability-adjusted life years. Again, more than 2/3 of all of these are occurring in our part of the world. So that's the starking statistic. When it comes to obstetric care, 2.6 per 1,000 hospital discharges worldwide are accounted for as adverse events. Obstetric adverse events is also associated with an excess mortality of 15 deaths per 10,000. And then in Ghana, the prevalence of obstetrics AE is about 12%. This is a study that was published. So another is that, the thing is that the healthcare system is expected to cure diseases and to alleviate our pain. But unfortunately, it also causes preventable harm and suffering. And adverse events lead to loss of trust in the healthcare system by patients and reduced satisfaction by health professionals and patients, because this impacts one of the dimensions of healthcare, which is patient safety. So this presentation is from a publication that will be in soon in the Journal of Patient Safety. One of the things I'm presenting on is to look at the degree of preventability of adverse events. And this is informed by a study that we did. I'll show you the authors as part of my PhD work, which is also published. And then it was the method was a 2-method approach. We used a cross-sectional study and then a case control study. So for the statisticians amongst you, that is the methodology. We reviewed about 1,400 plus folders. And this is it. We saw that 87% of the adverse events that occurred were preventable. And look at the statistic here. We don't have time, but so the cumulative is that 87% of the adverse events, so only 12% of the adverse events were not preventable. And then these are the causes. So the health system building block was used. So this big part, which is the leadership and governance block. So these variables are the causes as far as this particular block is concerned. This is from the Likert scale part of the data collection that was done. So you see guidelines, protocols and guidelines, availability and adherence, care standards. Sometimes, or most instances, standards of care were not available. So we were just practicing and working. There are issues of teamwork, competence, knowledge and skills of the providers, decision-making aids, competence, knowledge, and then the attitude and motivation of healthcare workers. So all of these, and the absence of all of this resulted in a preventable adverse event. So accounted for the part of the 87% that we are seeing. The other building block we saw was the hospital management information systems, where there were incomplete documentation. Sometimes we'll write or we'll not write. When we write, we don't write fully. There's the lost progress notes, which are not in the patient records and their folders. Our written communication were also very poor, sometimes very difficult to see and less legible. Our handing over were inadequate as far as the care was concerned from the patient folders. And then oftentimes also there was failure by the providers to arrange for a procedure for the pregnant mother. And then there were also inadequate use of antenatal care by the pregnant woman or the obstetric client. So all of these also accounted for the adverse events as far as the hospital management information systems building block was concerned. When it comes to service delivery, we saw significant delay, especially in diagnosis, which greater than 12-hour delay. So whenever there is a greater than 12-hour delay, any of these events are going to occur. Availability of blood and blood products, availability of test results. And then we also saw where there were problems with scheduling or provision of the services that are required by the obstetric client. So there are some scans that has to be done. There are some medications that has to be served, or some areas of the hospital that has to be accessed to ensure that adequate and holistic care is provided. But when there are problems with such scheduling, then adverse events occur. What we have seen and from the work is that, you cannot just hold one building block and say that, your system will be perfect. It is about synergy and our ability to comprehensively work around all the health system building blocks. And for the work that we saw that these impacted very significantly on the 87% preventable adverse events that we saw. So if we should do anything as far as reducing preventability is concerned, if we are mindful of all of these, we should be good to go, which are the leadership and the variables that were shown, the health information and the variables that were shown, the medical technology and the variables that were shown, and the service delivery. But more importantly is for us to ensure that we are addressing all of them and working synergistically, ensuring that all of these building blocks are synergistic as far as advancing the cause of the patient and the healthcare system is concerned. And then, so these are conclusions that I also conclude that we should design our healthcare system to ensure that it is safe for both the patient and the providers. These are some brief recommendations from the work that we should include and ensure that there is mandatory reporting and strong monitoring of adverse events in our facilities. We should improve upon the communication process between members of staff on the one hand and between members of staff and patients on the other hand. That is a very big deal, and how we are also able to empower patients to speak up, to support the healthcare team in averting the occurrence of adverse events. When it comes to communication, this is one long-standing tool and a tried and tested tool, which I believe we can be testing and using in our facility, the SBAR, which is the situation background assessment and recommendation that can guide us as far as effective, more structured method of communication in our facilities are concerned. The other is we should also ensure there is a coherent quality improvement and patient safety program in our facilities. There should be succinct and clear arrangement for accountability. I mean, sometimes, so all of these events we saw were all hidden in the folders. Some of them, the patients died. Some of them, there were readmissions and so many other things that happened to the patients that they didn't know. So there should be some systems of accountability that are available. We should be reporting these adverse events. There should be systems of reporting in our facility. And again, protocols and guidelines should be made available for the care processes in our facilities. This is also non-negotiable. And finally, but not the least, is creation of a patient safety culture. I mean, we are talking patient safety, and we cannot improve patient safety where the environment doesn't encourage learning, where the environment doesn't encourage reporting, and where the culture is not just, but where there is incident victimization, and there is that naming and shaming whenever there are flaws and whenever adverse events occur. So we should be looking at creating a patient safety culture as well, as much as possible. So that is it, my brief presentation. And I say, I acknowledge all of this, and more importantly is the first person, Dr. Esena, who passed away recently, my principal supervisor as far as my PhD thesis and the publications were concerned. Thank you. Over to you, moderator.
Thank you very much, Elom. I'm going to give Mary the chance to share screen. If you come off, we are all very welcome to share our questions. If you put them in the chat box, I will read them out for you. But we're going to do both presentations back to back and then have a short moment for you to ask questions.
All right, Ruth Pearl, can you hear me?
Loud and clear.
Great. Like I said, we from Acquire are delighted to be a part of World Patient Safety Week. You've already had a chance to meet me, and I was delighted to greet you all. So I want to get straight into the topic. This year is a year we will all remember because we have all been coping with COVID. And it is a result of some of the innovations that we've seen that have given us an understanding that there's a lot of robustness and potential within our systems, and we need to do more to bring it out. And so you might say to yourself, given that this is Patient Safety Week, why am I going to be talking about employee well-being? And I want to point out that there is a very strong association with patient safety and employee well-being. To quote one of the landmark articles in PLOS One, Dr. Hall and colleagues said to deliver quality patient care, the care must first and foremost be safe. And the findings of this review suggest that staff well-being play an important part in patient safety. And because of that, we really felt that we needed to address the issues. Now, COVID presented a perfect storm for us at Kajabi. And it did that in multiple ways. Fear was rampant among staff as well as patients. We had the situation where staff couldn't get to work because the buses and public transport would not pick them up due to the fact that they were standing in their nursing uniform. Individual staff also were very fearful because they're like, my family's abandoning me, in the sense that they don't want me to come near them and see them because they're afraid about getting the disease as well. And this was compounded by the fact that revenue was down due to elective surgery being stopped. And people were getting asked to take vacation at a time they wouldn't have preferred. So in every single way, COVID presented the perfect storm. And that meant if we were going to address employee problem issues, we had a problem. How do you create a safe space in a perfect storm? How do you give a space so staff can talk about their own feelings, comments that are potentially critical of management? And so that provided an opportunity for us to get creative. The goal we had in addressing this was to support staff well-being. We wanted to identify what staff needed most and provide real-time feedback loops for decision makers so they could make rapid changes to support staff. And we wanted to help staff identify coping strategies that they could use. And so we came up with a very simple solution. We started running small focus group discussions. These were run by neutral facilitators. In fact, it was our community health team, a team that does a lot of participatory research and community engagement, but they work outside the walls of the hospital. So they were known, but not well known. And we asked people what they were feeling and what they were thinking. And in order to do that, we asked them to put it on a sticky note. And so we were able to offer a mechanism where people could give significant input, both to how they were feeling and how they thought Kajabi could help them. In addition, to make the place safe for a discussion, we got institutional review board approval as another way of assuring staff of confidentiality and protection. So like I said, we had debrief sessions that will follow a qualitative focus group format. We captured data on sticky notes. And the final point here is essential. Every day, at the end of the day, management came by. We put the flip charts with people's information up on the wall, and management took a look at it. So we asked two sets of questions. We asked first about their personal coping strategies. What are the things that are you doing to help you cope? And then we said, what do you think Kajabi should do for you to help you cope with COVID? And this is what it looked like. You can see that personal coping strategies were identified, and people picked up on things and shared them with their colleagues. One of the big wins at this stage was not only identifying what might be working for someone else in terms of a personal coping strategy, but the recognition that if you were struggling, you were so not alone. How many of us see a coping strategy we use to get through COVID? Everything from prayer and meditation to listening to music, to overeating, that's what the grazing refers to avoiding news. It was a great and rich discussion about how people were personally coping. Then, when we looked at that and summed it up, you can see what the top 5 personal coping strategies were. People needed their family. They also coped by watching movies and listening, Bible reading, and prayer. But it's also, we went to the next step and said, what can Kajabi do to help you cope with COVID? And it's funny because all of a sudden people started writing on more than one sticky note. And you can see that people had a lot to say about how they thought the organization could support them. Things like giving day-to-day updates, ensuring staff safety. One of these was about, as a staff member, if I get COVID, will I be covered from insurance in the hospital? And as we daily had management come and take a look at these flip charts, they walked with pen and paper in hand and said, what is something we can do? And here's the themes that came up as we looked at this overall. Staff wanted institutional preparedness. They had very specific suggestions about employee well-being and COVID risk reduction measures. And here's an example of how we displayed what happened. Kajabi staff raised concern during the debriefing sessions, and Kajabi Hospital answered. You can see that one of the early things is we need drills and protocols laid out. What staff didn't know is that the COVID response team had been developing them, and they accelerated the full-scale rollout. People needed to know how to use PPE. Over a series of a couple of weeks, 600 some frontline staff were fully trained. Staff said they needed more communication. And because of that, the executive director started a video update series, short YouTube videos that were circulated on individual departments and divisions' WhatsApp feeds so they could see what was actually going on. There was a need for spiritual encouragement, and our chaplains department started an electronic media devotions. And they sent out both an email devotional that was written along with a short YouTube devotional for staff. Another interesting thing they pointed out is at the time when the cafeteria services and restaurants were being shut down in the country, Kajabi was still doing food service. And so we immediately took that comment and moved to only takeaway food service. And so we visualized a wide variety of the things Kajabi staff suggested and acted on them in real time. So what were the keys to success in doing this? Well, I think one of the keys is that we chose to look for opportunity in adversity. Number two, we had management that said, we want to help employees. Is there any way to do it? And when the suggestion of having confidential debrief sessions was posed, they were 100% for it. Management staff did not participate in those debrief sessions. Separate opportunities for management were provided. That meant we really had an enabling environment. And one of the things is that as they looked at what Kajabi employees and staff thought would help their well-being, while management knew they couldn't do everything, they could find the low-hanging fruit. Another thing that really contributed to success was being able to visualize progress. The progress report that you saw was something that we would put every week or so right on people's WhatsApp feeds so they could see. As one crisis was addressed, as you know, during the acute time with our early management of COVID, another crisis came up. And so people forgot that you'd done anything, and they needed to see and visualize it. And finally, success means not working alone. I want to applaud and give credit to the team who worked together to make this happen so that Kajabi management could have real-time feedback during a crisis on things to do to make employees feel safer and more secure. With that, I want to say thank you and turn it back to Ruth Pearl.
Thank you, Mary. Looks like the internet went down at just the right time. We thank you very much. It's a really detailed presentation, and I think an opportunity to walk into the minds of the frontline healthcare workers when they faced COVID-19 for the first time. And so we'll take a few minutes, 5 minutes to if there are questions for Elom and for Mary. One of the questions I have for Elom to start us off, you're welcome to write your questions into the Zoom or unmute or put your hand up, and I will encourage you to unmute and you can ask your questions. Elom, do you ever share advanced events with the lead who were interested in taking some of the reporting? Because I noticed that was one of your recommendations. So I'm interested in hearing how they responded to your recommendations.
Yeah, so I think they responded well. It's one of the facilities, for instance, that we are supporting. So as far as response is concerned, yes, I think they responded well. They have a very forward-looking facility head. So that is what I will say. Over.
Thanks, Elom. I don't see any more questions, so should I go ahead and just ask Mary a question? How much of the things that were written up when this study was first done, because I know it was done mid last year, right? How much of that is still in practice today?
Well, to be honest, the communication patterns have continued. But as there were changes in the COVID epidemic and the requirements and regulations from the government for reducing spread, a lot of things changed. For example, people became less fearful and the public bus system started picking up our nurses again. So we didn't need to run extra transport to try and get them. And that was a big deal. Our cafeteria had different seasons depending on the surge, where we do takeaway and where we don't. Things that are definitely used, though, are building these communication patterns. And so I think communication that would move through departments and divisions, short YouTube videos are things people are still using.
I don't know if everyone can hear me. My internet is a little bit unstable. Lydia has a question for you, Elom, in the question box, in the chat box.
Yes, so I've seen Lydia's question. I mean, so Lydia, please, as for near misses, let's forget, because even the events are hardly recorded. So I mean, in the
Wow.
Yeah, so I think as for near misses, I mean, it wasn't. We never saw any near miss in the folders. The events were even hardly ever. The events were even hardly reported. So that's what I I'll say. And what maybe I'll quickly add is, I mean, as far as improvement is concerned, I think we could start with either or both. But for in our settings, when it has to do with improvement, we may choose to start with the adverse event and identify which events we should be reporting and selecting. Thank you. Ruth Bell, over. Thank you.
Elom, what about the outcomes? What were the outcomes of those adverse events?
Sorry, our internets are not working in tandem. But thank you very much, Elom, for giving frontline from frontline healthcare perspective. So, and it's world. Oh, okay, yes, there was a part 2 to Lydia's question, Elom. Do you want to go ahead?
Okay, can you hear me?
About the outcomes of the...
Yes. Yeah, so I mean, some of the outcomes were death, as you saw in the presentation. Another outcome were the SSIs, or the surgical safety infection. I mean, another outcome that we saw was the third degree tear, as far as the clients were concerned. So these are some of the outcomes, and there was also hemorrhage, postpartum hemorrhage, as some of the outcomes. Over.
Thank you very much, Mary and Elom. I'm going to invite Jackie and Eunice to turn on their cameras. It is World Patient Safety Week, and we finally get a chance to hear from some patient experiences. Jackie and Eunice are only starting us off. We're hoping that all 51 of you will be glad to join the discussion. We have just a few questions. The only thing that we request is when you do speak about your patient experience, please do not let us know the name of the hospital. You're welcome to tell us if it was a tertiary hospital or level 2 hospital, but don't tell us the name. You can tell us the country and every other thing, but we really do not want to be vindictive in that regard. So welcome, Jackie, and welcome, Eunice. I think we can start with Jackie and then Eunice. Could you tell us your name? And then I asked you a question a little bit earlier. It's the COVID-19 year. What is one thing that has impressed you about the healthcare system in your country, in your environment over the past year? So we can start with Jackie and then Eunice, go ahead.
Thanks so much, Ruth Pearl. Yeah, I feel a little bit of an intruder because I'm the chief executive of CASASA, but I was also a patient last year, and I wanted to share my experiences. So in terms of COVID, I think 2 things have impressed me the most. One has been the collaboration between the public and private sector. And the second has just been the amazing resilience of the frontline healthcare workers.
I agree with you on that. Eunice?
Okay, so thank you so much for this opportunity. So personally, I think that the dedication of the frontline health workers has been something that has really impressed me, because looking at how that there was a lot of fear in the system and all that, but they still went ahead anyways to help manage the situation. I think it's a very commendable something they did. Yeah.
I agree with you. Okay, so we've tested our mics now. Now the floor is yours. Jackie, tell us about your memorable hospital experience. What went well? What didn't go well? What would you recommend to the healthcare leadership and to the frontline healthcare workers if you had the chance? Go on ahead. The floor is yours.
Thanks so much, Ruth Pearl. Yeah, I had to go in for surgery. I broke a very small bone in my foot last year, and I needed to have surgery. So I went to a very new, modern private hospital. I'm very lucky that I have insurance to enable me to go into the private sector. Now, my first experience was that I arrived in the ward I was supposed to be a day case. I arrived in the ward in a wheelchair, holding my crutches, and I was not able to weight bear on my foot with a broken bone. The nurse came up and introduced herself, not by name, but just introduced herself and started filling in paperwork and assessing me. And because I'm a nurse by profession and because of the work that I do in terms of quality improvement and accreditation, I can't help myself but read the documents that they write. So when she left, I picked up the documents and I read. And on my falls assessment, now I had arrived in the ward in a wheelchair. I was using crutches and I couldn't weight bear on the leg on which I'd broken the bone. My falls assessment was low risk. So I said to her, why would you have me low risk? She, oh, you look pretty fit and healthy to me. So I was like, okay, let me just go through this with you one more time. So then I was eventually taken down to surgery. I got to the theatre. They took me up into theatre, put me on the table, were about to anesthetize me. And the surgeon suddenly said, oh, hold on, they've sent me the wrong plate to pin this bone. You need to go back into wait. So I was sent back into the waiting area in theatre. And then they told me it was going to be at least 2 hours before they would get the correct piece of equipment. And I was like, you want me to lie on this trolley in the cold theatre waiting room? So they took me back to the ward and I waited for 2 hours while everybody else had lunch. Went back to surgery, everything was fine. I was done. They decided they'd keep me overnight because now it was late. And they gave me strong medication. I had a lot of pain. They gave me pethidine. And at some point I came around a little bit and I saw a nurse and I said, excuse me, I need to go to the bathroom. And she said, oh, okay. So I started to get out of bed and got a hold of the bed and the crutch and walked towards her and she walked away. And I was like, okay, I've got 2 crutches, I can manage this, I can get to the bathroom, it was quite close. As I came out of the bathroom, another nurse walks in and said, you must ask for help when you're going to the bathroom. You had an operation, you can't get out of bed on your own. And luckily for me, one of the other patients said, she did ask and your colleague just walked away. So there I was again at risk of a fall. The next morning I woke up and somebody came to take my temperature. And I said, excuse me, I didn't see you spray your hands or wash your hands before you came to me. And she looked at me, she went, sorry? And I said, no, you can't come and put a thermometer near me if you haven't cleaned your hands. And she shrugged, sprayed some sanitizer on her hands, did what she had to do, took my blood pressure, took my temperature, moved on. But the most serious was, by then I was now, the pethidine had worn off, I was now quite compos mentis. And I watched I think the staff nurse came in and she had 3 dishes on a trolley. She went to the lady in the bed next to me and she gave an intravenous medication to this woman. She then put that dish back on the trolley, picked up another dish, went to the woman opposite and administered an intravenous medication. She went back to the trolley and she picked up a 3rd dish and she walked towards me. And I said to her, stop right there. You are not touching me until you have washed your hands. And she kind of looked at me as like, sorry, what? And I said, no. I've now realized, I didn't quite notice that you went to the 2nd patient without washing your hands. Now you want to come to me. These are intravenous medications that you are giving. So she went and washed her hands, she came back, she gave medication, and she walked out of the room. The other two women looked to me and said, we have been here for more than 5 days and we never knew that. And that for me was the tragedy, is I'm qualified in nursing. I know that this is what you should do. And my fear is that so many patients don't know that they have the right to challenge the staff if they don't do things correctly. And say when I walk down the corridor, I hobble down the corridor on my crutches, the place was full of posters about hand hygiene, about infection prevention and control. It was all there. And I took the trouble to write to the nursing services manager and say to her, these were my experiences in the job that I do. I have to tell you this. But my life was at risk of somebody not washing their hands. I mean, this was March. It was just before the COVID pandemic. So it was shocking to me. These were all qualified nurses that knew better, that have been trained to know better. And the comment from the nursing services manager is, oh, we've got a lot of people coming to us from other provinces that just don't seem to have been as well trained. And what are you doing about it?
Okay.
So let me leave it there.
That's a really good storytelling. We will go to Eunice and then come back with some questions.
Okay, hello, Ruth.
Hi, Eunice.
Yes, please. Can you kindly take me through the question again?
So we are asking about your memorable experience in a hospital recently, and then tell us about what went well, what you feel didn't go well, and what you wish could have been done differently.
Okay, all right, thank you. So I'm not really a hospital person. I don't visit the hospital. I was pregnant. That's why I visited the hospital last year. So I visited two. So I visited two hospitals. One was a public hospital, and the other was a private hospital. So I'll just talk about a few things that I realized was similar in the two hospitals and some disparities in the private and then the government hospital. Okay, so with the two hospitals, my doctors were good. I really enjoyed their service because they gave me the opportunity to ask a lot of questions, and then also I was able to get the answers that I needed. Yes, so that was one good thing that I had from my hospital. But there was this thing about the private hospital I used to visit. The environment was very neat. There was the washrooms were neat and all that, but that was very different when I started visiting the public hospital. I mean, you go to the hospital, and because I was pregnant, I was almost always doing urine proteins upon every visit. And whenever I go, I had to use the washroom, and it's not a place you would want to use. Okay, so I would rather go to the private hospital, do my labs over there before I bring the results to the government hospital, because the washrooms were not good. You wouldn't want to use the place. And I mean, considering that it was being used for pregnant women who are prone to infections, it wasn't the best at all. So that's one experience that I had, which I didn't like, yes, especially with the government hospital. But one other thing too that I like very much, and I think it helped me because I'm a first-time mom, and I learned a lot, was with the public hospital. They had something called pregnancy school. So for me, I learned a lot during the pregnancy school. I had a lot of information that I wouldn't have gotten if I hadn't been attending the pregnancy school. And the good thing about the pregnancy school was that our coordinator was good. She was always calling us, are you coming? And if you are not able to make it, she asks you why you weren't able to make it and all that. So it helped me, it's prepared me mentally. And then also there was the opportunity given to our spouses to also come and learn about pregnancy, what to expect, the red flags and all that. So it was all good for me actually when I visited the public hospital, especially with regards to public education on the pregnancy experience. Yes. So also one of the things that worked well for me during the pregnancy school, because it was like one of the good things that happened to me actually during my visits, was how that there were exercises. So if you are not even able to exercise at home, you know that when you come for pregnancy school, there are lots of other pregnant women who encourage you and all that. So it was really good. Now, one of the things that did not work for me during my hospital stay. So I think a week or two before I delivered, I was admitted, and the ward wasn't good. It wasn't good at all. There was a lot of mosquitoes in the ward. The nets were torn, so I mean, mosquitoes were all over the place and all that. And there wasn't much that could be done about it. There were fans you could use, but fans weren't properly working and all that. And so, because I had a rise in temperature, they had asked about, they wanted to take a COVID test. I had actually taken about 2 or 3 COVID tests, and I never had results, despite the fact that I kept following up on my results. Every time I go, they tell me my results wasn't ready. But I never had my results. It was like 2 or 3 different COVID tests I took, and I never had results. So this time around, here I am in the ward, which is mosquito infested, and they wanted to detain me a little more. So I was fine, but they wanted to test for COVID. So now they came, and then they said they would detain me for 1 more day so the COVID team comes to take my sample. I waited for the day, the COVID team never came. 2 days, 3 days, the COVID team never showed up to take my sample. And it was getting irritating because here I am okay, and I'm in a ward with a lot of mosquitoes. I'm a pregnant woman, and you're asking me to remain there just so that your COVID team comes whenever I do not know. And so we had to insist, my husband actually had to insist that they discharge me before I was discharged. And then there was another unpleasant thing that also happened at the time that I was supposed to deliver. So there was a number of complications. Should I call it complications? But yes, there was things that didn't go as expected. And so I had to do an emergency cesarean section, and it didn't, so I was supposed to sign a consent form, but I wasn't in the right state of mind at all. And so my husband was expecting that since he was the immediate family member who was there, the consent form should have been given him, and then things explained to him why the CS had to be done and all that. But that also didn't happen. And all that happened was, in my pain, I mean, you're in labor, the labor is not progressing as it's supposed to and all that. And then they bring you the consent form to sign. I didn't see, I can't remember a word on the form. I just signed because they said I should sign. And I mean, I wanted the relief and all that. So I thought that they should have probably discussed it with my husband, or and then explained it to them. Yeah, so talking about the time that I was also admitted and they were waiting on the COVID-19 testing to be done, I remember there were a few health workers who were, I don't know if I should say they were scared. So because of that, some of them couldn't really come close to me and all that. And I think I overheard one even telling the other that wasn't she afraid speaking to me and coming close to me because it's a suspected COVID case, and it wasn't really a nice experience for me. But another thing that worked for me was that the staff, some of them kept checking on me, and so it was good. The morning staff, afternoon, night staff, they all came checking the vitals and doing all that they had to do. It was good. And one thing that I would like to say is if the healthcare workers can take the concerns of patients to heart, maybe to communicate it with their authorities. So I realized that Jackie actually went the further step to write to the director of the nursing service. I wasn't able to do that, but I wish that healthcare workers were able to report to the authorities about some of these things that are happening, like the wards were infested with mosquitoes. At least something could be done about it, because you go with a condition and then you are coming back with another condition, which really is not right. You get it? So I think that there's something that can be done about it. Thank you very much.
Thank you, Eunice. Wow. And congratulations.
Wow. Wow.
Yeah.
Thank you.
Wow.
Thank you. Thank you. Yes. So Elom, you can start us off. So this conversation is really an opportunity to give frontline workers a chance to know what must they know and do. They are getting their chance to hear from patients, hopefully. When we did the show by hand at the beginning, more than half of the people here were frontline healthcare workers. So now we get a chance to actually say, from the patient perspective, what in the World Patient Safety Week, what is the thing that we wish that frontline workers knew and did differently? So we want to open the floor to anybody. We have until past to have this conversation. You are very welcome to start us off, and let's see where the conversation will go. A gentle reminder, we don't want any names of any identifying factors, but we really do want to hear from the rich, real life lived experience of you as a patient. Go ahead. I can see Elom has raised his hand. Please go ahead.
Yes, I just wanted to, some observation I make between Jackie and Eunice's submission. That one, Jackie was very assertive and was able to speak to the care issues and the challenges that she was observing. But you see that Eunice was not, I think, pretty much reserved and laid back as far as the care she was receiving was concerned. And for me, these are some two striking attitudes when it comes to ensuring that patient outcomes or our healthcare outcomes are significantly improved. That as patients and as recipients of healthcare, we should be assertive and we should be able to speak up as far as the provision of care is concerned, because it is our body, and we should be able to do that very nicely and very courteously, so that, I mean, it provides an opportunity to learn, so that our outcomes improve. And because when outcomes are improved, both the patient and the providers are all happy. So that's the observation that I made, and I thought I should share. Thank you very much. Over.
Mm-hmm. Thank you, Elom. As we're waiting for someone else to raise their hand and share with us the patient experience, one of the things I thought about, and Jackie, it's good you have your hand up, I was gonna ask you, as I listened to you, and I thought if I was in your situation, maybe it's the Kenyan context, I would be afraid of what the nurse would do. I think for many of us, that's probably the reason why we keep our mouth shut, even if we see problems. What did you feel about it? Go ahead, Jackie.
No, that's a very, very valid point. And I think that's why many people don't speak up, Ruth Pearl, is because they're fearful of what the repercussions should be. And I mean, as a nurse, I find that very, very upsetting, because as a professional, I took an oath, the Florence Nightingale oath, that I would do nothing to harm my patients. And somewhere along the line, we seem to have forgotten that. Or some nurses seem to have forgotten that. And I think it's really important because I was able to be assertive because I'm a professional. And when the two women in the ward with me said, we didn't know this. And I said to them, well, from now on, you don't let anyone touch you that has not washed your hands. And it's okay to do that. It's absolutely okay. And I had an experience in one of the hospitals we were working with in the accreditation program, where they had a very, very low incidence of hospital-acquired infection in the neonatal unit and the pediatric unit. And the reason being was they said to the mothers, you don't let anybody touch your child without washing their hands, because your child could be harmed. Now, if you tell a mother that your baby or your child is going to be harmed, that mother's going to be protected. And I think that's the kind of message we've got to give to all patients. It's not about touch. You can not touch my child, but you can also not touch me if you don't wash your hands. And I think COVID has perhaps been a wake-up call to professionals and to patients that it's now, we now all know that you can't, you know, the control of infection is so paramount. But I do appreciate that fear factor. And I think as professionals, nurses and doctors and other healthcare professionals have got to understand that patients have rights and responsibilities to protect themselves. And we mustn't penalize them for that.
Yeah, that's absolutely true. Thank you, Jackie. Marilyn Keegan says to create assertive patients, there should be a patients for patient safety group created in Africa. Is there, I know there are various patient groups, associations in Ghana, not necessarily patients for patient safety. I want to invite Dr. Sonny of Patient Safety Africa to speak about the patient safety associations available. Dr. Sonny, are you there? I thought I saw him. But you're welcome to comment. Anyone else that is interested, please just go ahead and unmute yourself and go ahead. Are there patient safety associations, sort of middle ground to those who might not be as courageous as Jackie?
Hello, good evening, everybody.
Good evening.
My name is Godwin Museka from Zimbabwe. Thank you for convening this group. I'm humbled to be able to share my experiences. Mostly I'll share my experiences that I've encountered at government hospitals. The pleasant experience that I had at a government hospital occurred to me 3 years ago. My mother was sick. I took her to see a physician. She had been diabetic for over 30 years, and she was having problems in managing sugar, blood levels. I was impressed because as we arrived at the institution, we managed to receive pamphlets that were talking about a patient charter and the patient's rights, as well as the patient's responsibilities. In addition to that, they were also distributing pamphlets that were advising diabetic patients on the correct diet and to watch out for severe symptoms that would lead to other complications. What impressed me most about the pamphlets was that they were available in all the major spoken languages in Zimbabwe, which are English, Shona, and Ndebele. And that actually made it easy for the patients to understand the message that was being propounded by these pamphlets. I'll rush to discuss with you and share my worst experience. This was also an experience that I had at a government institution. being admitted to neonatal intensive care unit. There had not been any swabbing that was being done for quite a long period of time. And we suddenly started to experience neonatal deaths. I would like to mention that I'm a quality assurance manager for a hospital in Zimbabwe, which is based in the capital city. And because we were not doing swabs in the neonatal intensive care unit to monitor for resistant bugs like medicine-resistant Staphylococcus aureus and other very stubborn bugs, we experienced 5 neonatal deaths. And when the postmortems were done and swabs were collected, we discovered that these neonates, unfortunately, had contracted Klebsiella. This these unfortunate events continued to manifest, and within a period of a month, we lost almost all the patients that were admitted in the neonatal intensive care unit. We actually raised the red flag and we requested that the neonatal intensive care unit be closed and further investigations be done. And that's when we discovered that the Klebsiella bug was really wreaking havoc. That was my worst experience because I actually imagined that there was laxity on our side. We failed to protect these lives, and I also felt that we ought to have been teaching our staff to be meticulous in the way that they exercise infection prevention and control. I belong to Patient Safety Africa Group of Zimbabwe, the Zimbabwe chapter. I'm also a member of AFLIXA. We have had a lot of sharing and knowledge gain with the lessons that are being conducted. Thank you so much. I'm humbled to be able to present on this platform. Over.
Thank you very much. Thank you very much for sharing a very good example of failing forward. It was not the example because there was a lot of learning, and hopefully things have changed since then. Now, because I want to make sure we hear from everyone, I'm about to open breakout rooms. You are coming together to just answer one question. The question is, what must frontline workers, what must frontline healthcare workers know and do? And if each person in the team gives 1 point each, then we'll be able to come back 5 minutes later and have a very quick plenary responding and answering and hearing from the different groups and the different discussions. So you're going to have a 5-minute discussion. Please enter your breakout rooms quickly because we want to end in time. You're answering the question, what must frontline healthcare workers know and do? It's World Patient Safety Week, and we want to make sure we come out with something tangible for them to do. Go ahead and click the button to get into the breakout room.
Hello. So I think we should get a lead and then we can start. Who is leading us? Over. Hello, please, who is leading us? Over.
Elom, can you lead us? We are only 3 here.
Oh, no, Labano, please lead us.
We are only 3.
Yes, so please lead us.
Where are the others?
Yes, the Galaxy S9, please, can you please, let's introduce ourselves quickly and where we are from.
Okay, my name is Waja Klabano. I'm the quality manager for Life Healthcare Gaborone Private Hospital in Botswana.
Botswana, I am Ghana, Galaxy S9.
I am Ghana, Sophie. Ghana, Sophie.
Okay.
Sophie, can you lead us?
Hello, Ghana.
Yes, Sophie, we've heard you. We are asking you to lead us. There's another one has joined us, Susan Mutua. Please, where are you from?
Hello, I'm from Kenya, thank you.
Oh, okay, thank you. So, Susan, can you lead us?
I just came.
Yes, it doesn't matter. We were waiting for you.
Let me catch up with the team, please.
Oh, okay. So, Sophia, we were waiting for you. Is your mic? Waja. Oh.
Hello. Okay.
Yes, or you will lead. Okay, so please, can we write something? What should frontline health workers know and do? Can we share something? Who starts?
I didn't get the question properly. Does it mean in the context of caring patient safety?
Yes, in the context of patient safety, what should frontline health workers know? What should they be doing differently?
Okay. According to my perspective, I think frontliners should be able to know about the quality care of a patient. They should know how to manage patient holistically. And also should follow the guidelines and the processes so that they avoid adverse events.
Okay.
Because if they follow guidelines properly and they know what to do and they don't improvise, they will be able to not to have a lot of incidents or a lot of adverse events.
Okay.
They should also be able to communicate with the patients, inform the patient. An informed patient is a knowledgeable patient who can also take decision on the care.
Okay. Okay. So
any contribution from others?
Yes, Sophie and Susan, any other?
Welcome back, welcome back. Okay, so.
Hi, thank you.
Let's go ahead and we'll quickly, I think, begin to write down, maybe I should use the chat box for this, and just write down everything you say. What must frontline health workers know and do? Just unmute and go ahead and speak. You're welcome to type into the chat as well.
Frontliners should know that patient rights.
Patient rights.
They should know about patient rights. frontliners should be able to follow the guidelines on the care of patients.
Thank you. Waza?
To our group, Rupal, it was about protocols must be observed and healthcare workers must ensure they are safe to be able to provide quality care.
Yeah.
Health workers also need to have work improvement teams where they discuss activities and, critique each other to actually, constructive criticism. It's without blaming each other.
I like that, constructive criticism. We all need it. That's how we learn forward. Then just culture and work culture. Good. I can read what is being written. Standardized care, learn from what went right and what went wrong, and reflectively respond to that. Everyone should be guided by standards and SOPs. Frontline staff should have empathy. Oh, fantastic. It looks like we had a very engaging discussion. About safe places to disclose when things go wrong, learn from best practices. I just want to make sure that every idea that has come to your mind as you had this discussion is recorded. We're going to put all of this into a nice blog article and share it if you don't mind. The way that you heard about this webinar, I guess you get to read the article as well. And we are so grateful to begin the conversation. As we close, as I say, thank you for participating, for sharing your ideas. I want to remind us that today we are focusing on frontline healthcare workers. On Thursday, at the same time, 4 p.m. GMT, we are going to be having a conversation with CEOs, quality assurance managers, and we actually have confirmed people from Ghana, from Kenya, from Sierra Leone, from multiple countries. So this is going to be a really interesting discussion with frontline healthcare leadership. CEOs, quality assurance managers, telling us from their point of view what could be done better and what are they trying to do to address quality and safety issues. So please don't miss it. We're going to keep showing the poster. It's actually the same Zoom link, and then we'll get a chance to continue this conversation. From me, it is goodbye and thank you very much for being a part of this movement that hopefully we'll be seeing a lot more of, that is beginning an Africa-focused conversation. What can we learn from each other from a very similar context about bringing quality care to patients? Thank you very much. Have a lovely evening, everybody.
Thank you.
Thank you.
Thank you.
Thank you. Well done.
Thank you all.
Thank you,
everybody.
Thank you.
God willing,
Yes.
we'll catch up with you on Thursday.
I think we should all put our faces up for a picture, and
for
then
a group picture.
And yes, for a group picture. So let's put our faces up for a group picture, and then we can call it an evening.
Yep.
Oh, we are not seeing all the faces.
It's you.
Are you seeing it? I should screenshot the page.
Good. Okay, so we have some of our speakers for tomorrow also on. Good.
That's great. Thank you all.
Thank you. Oh, the pictures are not done. Please show all your faces. Excellent. Good. Thank you. Thank you all.
Thank you. Everybody.
Thank you.
Yeah.
Bye-bye.
Yep. Bye. Yes. All right. See you all tomorrow. On Thursday.
On Thursday.
Yes, see you on Thursday. Sorry.